Good afternoon, everyone, and thank you for joining us. This is Paige Hancock, Marketing Manager at Spok, and I'll be your moderator for today's webinar. Today, we'll be talking about paging for today's hospital, encrypted and connected. Tom Sain, Spok's Chief Information Officer, and Gerard Shallow, Director of Sales Enablement, will be sharing how paging today can drive much more than just simple messaging. Before we get started, I would like to go over a few housekeeping items. Everyone will be muted during today's webinar, but we still want your participation. Please submit your questions via the questions box, which is in your GoToWebinar toolbar, and then Tom and Gerard will answer as many questions as time allows after the presentation. We'll also be doing a few live polls throughout the presentation and look forward to getting your input on those. A recording of this webinar and the presentation slides will be sent to all registrants tomorrow, so please do feel free to share these with others at your organization. And lastly, you'll have the opportunity to complete an evaluation at the end of the webinar. We'd love it if you could take a couple of minutes to complete this survey. We truly do take your feedback into account, and your thoughts help our efforts to provide relevant and informative presentations. And with that, I'd like to turn it over to Tom, who will begin our presentation.
Thank you very much, Paige. We're going to start off today with a quick little poll, and Paige is going to read you a poll question.
That's right.
Go from there.
So it should be on your screen now. Our first poll question to set the scene is, what mobile devices does your organization support? So you can select multiple. There's one-way paging, two-way paging, smartphones, Wi-Fi phones, and voice badges. If you want to go ahead, it looks like we've got quite a few people putting their votes in, so we'll give you another second or two to submit those, and then we'll share the results. All right, looks like we've got the majority of votes in. All right, you should see those results now. So it looks like we've got a tie for number one. One-way paging and smartphones at 77%. And then next is Wi-Fi phones at 38%, just edging out two-way paging. And last is voice badges with 23%. Any thoughts on that, Tom?
Good thing. You know, it sounds like the audience pretty much matches our demographics, because the vast majority of our pager base, we have a little bit over almost 1.1 million pagers in service today in our network, and the vast majority of those are one-way pagers. And then we have, through our mobile offerings of our software set, we do a lot of work with smartphones environments, and the smartphones are very active in that regard. And we're seeing that there's an uptick in smartphone utilization, specifically in healthcare, that's displacing some of the paging business, but it's actually pretty and good to see it that the audience matches our demographics of what we're seeing in the industry as well. So that's great. Appreciate you guys joining the call today. So basically, Gerard and I are going to cover paging as most hospitals know it today. What is people understanding about paging today? One of the enhancements to a traditional paging environment is encrypted paging. Do a little bit of explanation about what encrypted paging is and how it works. And Gerard's going to talk about how connected paging is and what all that entails, and I won't steal any of his thunder, so we can go into that regard. And then we're going to talk a little bit about how Spok continues to invest in the future of paging. It is still a critical part of our business, and we expect to have it as a reliable service for the customer base for many, many, many years to come. And we'll talk a little bit about the differentiations with Spok and its product sets. So with that, we'll jump into it. Traditional paging is predominantly controlled by wide area paging, where you take your pager, you can go on and off campus, go home, go shopping, soccer games, all that kind of stuff, and your pager will work. And then a smaller subset of the base is what we call on-campus paging or on-site paging, where the paging vendor actually builds a paging network for you, ideally just used for campus-based coverage within your hospital system or healthcare system. Usually it's used for code teams where speed is of the essence. On a traditional wide area paging network, we design them with what we target is sub 30-second latency, or time for a message to be delivered from the time it's launched is about 30 seconds. The networks run a little bit better than that, but we design them so that you would get 30 seconds would be your I won't say a worst case scenario, but that's what we would average across the time frame. A lot of times when you want an in-house system, you want pages in 7, 10, 15-second intervals, so you can't compete with other entities for the bandwidth. So that's why people would go with an in-house paging network. We do see a lot of organizations that have had legacy in-house paging networks contacting us about either replacing their in-house paging network with an upgraded in-house paging network, which we can do for them, or a lot of them are actually just switching their in-house paging to wide-area paging because the speed of paging is so reliable and so at an acceptable rate. So we do see that happening in that regard. So it's both a one-way paging and to a smaller degree a two-way paging environment. A two-way pager is basically where you can receive messages, so it's like a one-way page, but the device has a QWERTY keyboard on it, so you can actually initiate a message out from the device to the network, then on to other people, whether it be an email, an SMS message, or et cetera environment. Still, part of the driving force is why there's still over 1 million pagers in our network is it's in a very affordable technology. An average cell phone today with taxes, titles, license, and all that kind of stuff costs about an average of $50 a month to have a smartphone on your hip and everything like that. The average cost of a pager is a bit under $8 a month. So quite a bit difference in the cost structure. There's quite a bit difference in the functionality between a smartphone and a pager. So it's really important that organizations look at what is the right communications tool for the specific end users within their ecosystem. Not everybody in a healthcare environment's ecosystem needs a smartphone. Physicians, definitely there's a lot of value add for having a smartphone with secure messaging on it and the ability to look at test results, et cetera, in that regard. Someone is involved with bed moving systems or whatever, moving a patient from their room to a CAT scan or whatever. A smartphone may not be the right tool for that person, where a simple alphanumeric pager where you can send him or her a message of what task needs to be done, and there are other closing loops within the system that's going to close the loop that knows it was completed. That might be the right solution based on the price point for those environments. So that's why we look at that regard. It is a very fast communications methodology, like I talked about, usually less than 30 seconds from initiation of messaging. But also the one-to-many architecture of paging plays a big role in there. When you have code STEMI teams or code blue teams where you need to initiate one message and send it to a group of people, whether it's 5 people, 10 people, or 100 people, with what's called common cap code paging, you can send that one message and all 100 people get it at the exact same time because they're all actually receiving the same message. So there's some advantages to that as well. It's a very reliable and survivable technology. During man-made and natural disasters, hurricanes, the bombing in Boston a few years ago, the broadband networks basically became useless, not necessarily because of their underlying technology, but it was oversubscribed. You know, you design, as an engineer, you design a wireless network, assuming that about 30% of your users are going to be using the network at any given time. Well, if there's a disaster, what's everybody do? You pick up the phone, check on your kids, your wife, your husband, your parents, whatever. You communicate, and that drives the utilization of the broadband networks way, way, way up. The reality is paging is not a consumer product. It's really a B2B environment, and it's built into workflows that the workflow environment is fairly consistent during both disaster and non-disaster scenarios, so your latency stays about the same. So it's really convenient and reliable, and it runs on a AA battery. So you know, I know I have to plug in my cell phone every night, or else it doesn't work halfway through the day. So you can put it on a AA battery, and it'll run for about 30 days on a battery. Again, during a disaster scenario, when Sandy hit the East Coast, power was out in some areas for 3-4 weeks at a time. You had people out in their cars starting their cars up to charge their phones. Well, gas was shortage as well. You had even on gas days where you couldn't just buy gas. So in reality, with all of our hospital customers up there and everything, their pagers work. If their battery died, they just replaced it because it's a AA battery. So very good in that regard. So one of the drawbacks to paging is a single non-encrypted pager is not fully HIPAA compliant. We meet part of the HIPAA requirements in one-way paging, but it's not fully HIPAA compliant, and that's why we really evolved it into the encrypted paging environment. I think with that, we're going to ask you one more poll question, and I promise that's the last one, so we won't bug you too much, but Paige is going to ask another question.
That's right. So for those of you who said that your organization does support one-way or two-way paging, we want to know also, does it support encrypted paging? So just a simple yes, no, or if you're not sure, we'd like to know that as well. So looks like we've got a few votes in. We'll give it a little bit longer. I can see changing quite a bit here. And I think we've got the majority. So we'll go ahead and close that up and then share the results with all of you. So it looks like for the most part, those on the call do not support encrypted paging. 21% do, and then 11% are not sure.
Okay. That's good. That 21% is actually higher than I thought it was going to be, because we really only launched encrypted paging last year. So that means the organization is doing a good job of getting the word out there and letting people know that we do have a HIPAA-compliant encrypted pager out there. So that's good. But there's a lot of opportunity, because the largest percentage of people were not using encrypted. So hopefully after today you have an understanding of what encrypted paging is and how it can work in your environment, and maybe it will help you solve a need that you're looking to solve in your organization. So with that, we'll jump into what is encrypted paging. Basically, it's a traditional one-way or two-way pager, all the identical features and functionalities of a one-way or two-way pager. All in addition to that, we've added the critical components that make it HIPAA compliant. We added the ability that the device you can manually lock it, or it will be set up for an auto locking, much like you do on your phone, that hits the compliancy, that if you set your pager down and walk away, someone's not going to be able to pick up your pager and read the messages that were on them. They have to know a code to get in it. Now, with a pager, it can't be an alphanumeric key entry. It's a key sequence. You press the left button once, right button once, middle button twice, or something like that. User defined. You pick your key sequence that you want to put in there to unlock your phone. And again, like inactivity timers are automatically kicked in. It supports 128-bit AES encryption, meets the HIPAA requirements for encryption. That is encrypted. All messages to the device are encrypted and then decrypted at the device. And on the two-way environment, a message launched from the device back to the network is also encrypted. So it is in the encryption environment. And then for people that have a lost or stolen device, again, you can't just leave it out there in the world to be accessed. We can remotely wipe the device from our business system. So we can also reset your access code. If you forget your key sequence, we are through our self-service portal, your pager admins can go in there and wipe your device or reset your environment, or you can call our support organization and they can help you reset your device as well. And it is fully HIPAA compliant, and part of a HIPAA compliance issue is not just the underlying technology, it's the commitment of the company to run operating policies, procedures, environments that are HIPAA compliant. And in that regard, we do execute business associate agreements, or BAAs, with our healthcare organizations to assure that we are running in a HIPAA compliant environment, and that helps your risk management people understand that not only them, they as the primary environment, but us as a subcontractor to you are HIPAA compliant and BAA and regulated environment. So that's in that environment. Some of the difference between the encryption that we've deployed versus some other encrypted pagers that are out there in the market is we took the tact that every pager should have a unique encryption key. So we developed an algorithm based on that takes a seed from the cat code of the pager and goes through our algorithm and creates a unique key for that particular pager. Some of the other pagers on the market, it's actually a common key. It's a shared key across every pager in the ecosystem, which again, to me, as a security expert and professional, that's not really the best way to handle encryption keys. So we took that approach where we generate a key every time we provision a device through our logistics organization to ship it out to the customers. We generate the key for that particular pager at that time. If it comes back for retrofit or replacement and we're putting it back into service, we rekey that pager again at that time environment. So it's environment. The key is unique to the cap code. And so as most people understand, you can have multiple cap codes within the pager as well. We key to the cap code associated, so your pager can actually have multiple cap codes with different encryption keys if it's part of groups. And then so a group message may have a different key than an individual personal message based on the function that we're going with that. Again, we thought when we engineered this, it was just a more robust security aspect of that environment. We manage and maintain all our keys. We don't share them out. No one else can know about it. If you ever bought some of the other pagers out there and you ever were part of the provisioning processes, you know the key. And people leave companies, go away. Some people are not always the best people to trust with that kind of stuff, so it's a shortcoming in my opinion. And I've already mentioned that two-way pagers are encrypted both forward and reverse channel, or messages to the device and messages from the device back in. Even though it's encrypted at the device level, we took the approach that all messages to an encrypted pager will be encrypted. We don't allow you to mix and match unencrypted and encrypted messages because, again, it opens the uncertainty as, are you sending a message to a device that the end user perceives as encrypted, unencrypted messages, but worse, you would be sending a PHI and an open unencrypted message content that really needs to be encrypted. So it's either an encrypted pager or it's not an encrypted pager from our approach on that regard. And really, we just try to make it keep as simple for the end users, the customers, as possible. Spok has two encrypted pagers, the T5 and the T52. The T5 is a one-way pager, and the T52 is a two-way pager. They're both capable encryption and unencrypted. It's the same pager, so if you have a mix of users in your environment, that some have encrypted pagers and some don't, it's still the same physical pager, so people don't have to relearn the menu systems and everything and the button sequences. It's the same for both. We just, when we provision the unit through the business system, we tell it it's encrypted, program it as a encrypted pager, and then issue the keys for it in that regard. Those two pagers are exclusive to Spok. We worked hand in glove with the engineering firms to design them, build them to our spec. They meet all of the stringent RF requirements we put on our pager environments. And from an RF perspective, they are equal to or better than what is traditionally the workhorse pager in paging, the Motorola Advisor Elite. We actually compare every pager we put in the market to the performance from an RF perspective to the Motorola Advisor Elite and make sure it meets that requirement or better before we certify it as a pager. So these pagers are very reliable from an RF standpoint in the field environment. It's a very, very powerful tool, like I've said, for the healthcare community that needs a nominally cost, I won't say low cost, it's a lower cost than smartphones, but it's not free. You know, for an $8 pager, you can have a fully HIPAA compliant encrypted device on your hip. So that's the environment. We held off on developing one of these for a while because we really weren't sure what was going to happen with the paging industry as a whole. And then also there was the advent of secure messaging on the smartphones. We weren't really sure how quick it was going to take off. It's getting some good traction. We see by the poll numbers that on this call it's 50-50 pagers and smartphones from that perspective. But it wasn't taking off as fast as we thought it was initially, so we recalibrated and we went and we did develop it. It took about 1.5 years to develop the encryption capabilities of these pagers, as well as developing the pager themselves because they are brand new pagers to the environment. So we listened to the customers. We heard you need an encrypted device at a nominal cost, which is a paging solution. They like the reliability, survivability of paging, but they needed it to be HIPAA compliant. So we listened, we spent the money, time and investment, and we came up with the product, and we believe it's a quality environment for you. And we like I say, we're seeing a good uptick. 21% of you on the phone already have encrypted pagers. That's a very good deal, and we hope to see a continued uptick in that environment because I just believe it still gives you the benefit of all the features and capabilities and functions of a one-way pager or a two-way pager, just with encrypted on top of it. So we didn't lose anything by going to encryption. Anyway. So with that, I'm going to hand it over to Gerard. I probably won't talk longer than I was supposed to, but I'll turn it over to Gerard.
Great, thanks, Tom. So one of the stats that Tom mentioned was that we provide just about 1.1 million lines of service for paging in the United States. That equates out to over 100 million messages that we deliver through our paging network, making us the largest paging provider in the United States. What we're going to talk about during this section is a little bit more about what Spok provides that differentiates us beyond the quality and size of our network, and that is that we can deliver what we're calling a connected pager. And connected, we'll talk about the reasons we refer to it as a connected pager going forward here. So in healthcare today, clinical communications means a lot more than delivering a message from that's sent by one individual to a device, a pager that's being carried by another individual. We have the need today, in today's hospital, to deliver messages to individuals that come from not only other clinicians but also other third-party systems, whether they're clinical in nature, such as patient monitoring systems, nurse call systems, systems that provide critical test results, but also non-clinical systems throughout the hospital. So messages have to come from a variety of initiation points to be delivered to the mobile device that's being carried by a clinician. While we, as we mentioned a couple times now, 1.1 million users, clinical users in the United States are carrying a pager of ours. As we saw with the first poll, it's kind of split 77%. Some are carrying pagers, some are carrying smartphones, and that's part of what differentiates Spok, is that we don't set up these silos and dictate what device our clinicians need to carry. We open it up to the individual users in the hospitals. So if we have users that want to carry pagers, great. We can provide not only, as Tom talked about, standard one-way paging, but also encrypted and two-way encrypted pagers. We can also allow for those that want to carry smartphones. We can allow for those that want to carry wireless or the voice badges. So whatever type of communication devices your clinicians are carrying, our backbone, our platform is able to message to that. So let's talk a little bit about what connected paging means. So as I alluded to earlier, messages and alerts and alarms come from a variety of different initiation points. And an amazing statistic is that there are over 350 alarm conditions per bed per day in the average hospital in the United States. And of those, anywhere between 85 and 99%, depending on the survey you read, can be non-actionable. So there's a lot of different alerts and alarms that are buzzing and sounding throughout the hospital, creating alarm fatigue. And it's alarm fatigue because of such a high, not only the frequency of these alerts and alarms, but also the high frequency of which they're non-actionable, don't require immediate follow-up. So while many of the endpoints for some of these alerts and alarms might be a pager, our technology, our platform behind the scenes allows for us to filter out and make sure that we're delivering the right alerts and alarms to the right device, if that's a pager or whatever it might be, by someone who's in a position to follow up. So we're not only taking these many messages and alarms and delivering them to different endpoints, we're doing so with a little bit of critical context. So we're taking perhaps a lab result or a radiological result and delivering it to the ordering physician, the doctor that ordered that test be done, letting him or her know that there's a critical finding and they need to follow up. We're taking patient care devices, nurse call, and delivering it not only to not only sounding out loud or delivering it to a particular endpoint for a nurse, but delivering it perhaps to a nurse or another caregiver who's in the best position to follow up. So if it's a nurse call, we're not just blindly delivering it to the nurse assigned to that room based on staff assignment. We're perhaps differentiating a restroom assist versus for someone who's a fall risk. We're differentiating that between perhaps just a water request or something that's lower priority that can be delivered to someone else other than the nurse assigned to that room for follow-up. EHR integration, we have some interoperability capabilities with EHR systems. So we can take something like a SEPSIS alert and alert a rapid response team, and we'll look at an example of that in a bit. And then other facility systems, non-clinical systems, door access control, fire alarms, any of the things that go beep and buzz throughout the hospital that are not patient related, we can send those alerts and alarms to security personnel on whatever device they're carrying, often pagers. We can send them to whomever needs to be notified, housekeeping, transport staff, on their pagers. So we're delivering all these different critical messages, be they clinical or not, to the device that's being carried by the intended individual, the person in a position best to follow up on that alert. So we'll start by looking at critical test results. So some really staggering numbers. There are, every year in the US, over 400 million radiology exams and over 6.8 billion lab tests. So lots of tests means a lot of different results and the need to communicate them properly. And in fact, for those of you who might be familiar with the Joint Commission, a third-party overseeing organization that provides some standards, the Joint Commission has a number of patient safety goals that specifically address the need to improve the process by which critical test results are communicated. And here's a look at why that is. Typically, this is what we see in a hospital, is that when a physician recommends a chest X-ray be performed, that physician is the ordering physician. The results come back, and the radiologist perhaps reads this, sees that there's a critical finding, something that requires follow-up. That radiologist is responsible for contacting the ordering physician, and They often will have to spend time picking up a phone, tracking down that ordering physician, letting him or her know, try to, perhaps leaving a message. They're going to play that game of physician phone tag. Meanwhile, the radiologist just wants to move on and do their next reading, and the physician is busy doing something else inevitably and has to wait, and time goes by before they're actually able to hear of the critical finding, and that patient, who's yet another critical party to this process, sits and waits for treatment. So we're able to greatly improve on this process, because when that physician orders the chest x-ray and the result does come back critical, we're able to remove that need for phone tag, and we're able to communicate directly with the pager or whatever mobile device is being carried by the ordering physician and send them a message such as you see on the screen here. And the example that we're using here is our T5 encrypted pager. So because this is an encrypted, secure, HIPAA compliant pager, we're not just notifying the recipient, the ordering physician, hey, you have a critical finding, speak to this particular radiologist. Because we can send the message secure and encrypted, we can send the full finding detail. So anything that the radiologist enters into the radiology information system, which is all the detail on the patient, very sensitive patient information that otherwise is subject to HIPAA compliance, we can send that directly to this device, to the encrypted pager that's being carried by the physician. So now that physician is able to get that message almost instantaneously and is able to follow up the patient and begin treatment. So this is much better for the radiologist because they're able to move on to their next finding. Certainly better for the physician who's ordered the test because they get their results as quickly as possible. And of course, the patient doesn't have to sit and wait and fearing for perhaps the worst when their test results come back. They're able to find out what the results are and then move forward with any necessary treatment as quickly as possible. Another example we'll look at is one that's generated by another third-party system, one for one at the bedside for patient monitoring. In this case, a ventricular fibrillation or a heart monitor. So when that alarm goes off, we're able to recognize, Spok is able to recognize the nature of the alert, and because this is a heart monitor, we note that it is a high priority message, and we're then sending it out to the care team, not just as one individual, but a care team on perhaps a number of different mobile devices, and let them know of the nature of the alert, of the need, the patient that's experiencing this alert condition, and whatever device they're carrying will alert them. And some devices might even allow for a higher priority alarm notification when that comes in. So we're passing along that priority message. So now we're delivering this critical alert to a mobile device for an entire care team, not just one individual that's assigned to the patient for them to follow up on. And that care team, if it is some sort of critical code situation, might be able to respond and begin defibrillation as quickly as possible because they're getting this alert right to their mobile device. I alluded to sepsis response, and some of you on the line today might be at a hospital that has some sort of sepsis control initiative in place. A lot of times this includes a rapid response team. So for sepsis response, the way it often works is that a nurse will take a patient's vitals and enter them into the EHR. So all the patient's vital statistics are entered into the EHR, and the EHR calculates an early warning sign based on a number of these different factors, based on a number of different vitals. That early warning sign is an indication that this patient, based on the vitals entered by the nurse, is a potential for sepsis, sepsis infection. So immediately the EHR makes this calculation and alerts the nurse that, hey, we've calculated an early warning score above a certain threshold. You might need to alert the rapid response team that's predefined for sepsis control to go and evaluate this patient. So once the nurse sees this alert in the EHR and acknowledges it, we're able to pull that and deliver it to the rapid response team. So this rapid response team might be a group of cross-trained individuals from a number of different departments that all receive a message such as you see here, in a secure and encrypted message that is able to give the patient's name, their room number, their medical record number, and the fact that they have an early warning score that's, in this case, in the 5 to 6 range, which to the recipient indicates, hey, I got to make this a priority, get down to this patient's room, I have that detail here, and we need to evaluate collectively as a rapid response team this patient and their condition, just to make sure that there is no sepsis infection here, and if there is, we need to immediately take steps towards controlling that. So sepsis control has become a major initiative for a number of different hospitals, and many of them have some sort of initiative in place or a process in place, as we just looked at. And obviously, Spok is able to help towards those initiatives and deliver these messages to pagers or whatever device is being carried by the members of the rapid response team, because they could be multiple. Code processes are also a major component of the way our customers use Spok to help clinical communication. So one in particular that we're going to look at, because it's a great example, is a code STEMI. So code STEMI, the acronym is ST segment elevated myocardial infarction, and it's essentially a heart attack. So when we have a patient that's admitted to the ED and they appear to be suffering from a heart attack, the hospital will call code STEMI, and that requires a number of individuals from different departments to come together to care for the patient. So in 2006, the Joint Commission put out a mandate that every hospital track what they call their door-to-balloon time. The door-to-balloon is so named because it's the time from when the patient enters the door of the emergency department until they're receiving cath lab treatment, that catheter being the balloon here. So that the Joint Commission mandate was that every hospital measure and keep it under 90 minutes. And this was echoed by the American Hospital Association as well as the American College of Cardiology, because there are physiological reasons for keeping it under 90 minutes, because after a certain period of time, the patient might, of experienced heart attack symptoms, the patient might actually be permanently damaged. So the Joint Commission and other organizations mandate this be kept under 90 minutes. So what tends to happen is when a code STEMI is pulled or is initiated, it often is a manual process. So there's one or a couple individuals within the hospital, sometimes they could be members of the contact center, that are required to be notified that there's a code STEMI taking place, refer to on-call schedules, refer to notes, refer to directories that could be in a number of different formats, and pull together a response team from the cath lab, lab techs, the attending cardiologist. We have to reference on-call schedules to figure out who's currently the ICU shift coordinator, who's on call for this role, that role. So it becomes a very manually intensive process that if we don't reach one individual, we then need to refer to who's the person that's responsible for escalations here. Who do I need to get in touch with to replace this person? So you can see why a lot of times this comes in over a 90-minute process. The little timeline at the bottom here indicates one process, one measurement that we saw with a Spok customer who was measuring their code STEMI at 129 minutes. So we were able to come in and automate this process and nearly cut this time in half. So we have behind, as part of our technology, behind the scenes, we have the directory, we have on-call calendars, we have escalations built in. So when the so-called trigger is pulled here for the code STEMI, we know all the individuals who need to be notified, who's based on call schedules and all these other factors. We know in the event that we don't reach them on whatever device they're carrying, we can escalate to other individuals. We know when we receive a response to them, if they're carrying perhaps an encrypted two-way pager, they can just with a single click or keystroke notify us that they've received the message, and we will stop that escalation to fill that role. So we're able to really streamline this process, and we've been proven to really cut this in half, this code STEMI response time in half. And I would say the same for any code process, even code blue, where you might have just a button on the wall that requires just, instead of a whole large number, a dozen people to be notified, like a code STEMI response team, if it just requires 3 to 5 members of a patient's care team to be notified, we can handle all those things and bring in the same concepts, escalations, and so forth. And on that subject, I believe this is the last bit I'll cover is escalations. So just want to give you an example of how paging plays into the escalation capabilities that Spok can bring to our users. So going back to the example we looked at earlier of a radiological exam, if we have a radiological exam that's been performed and there's a critical result, the tech will enter their finding into the radiology information system, and will feed that out to whatever mobile device is being carried by the ordering physician. So let's say that's an encrypted message to this doctor's carrying a smartphone. So that doctor receives the message on their smartphone, but 2 minutes go by and they don't interact with that message. They haven't seen that message. what we're able to do is have a secondary method of contact for that doctor. What that doctor might prefer is that a voice call goes out. So we have a text-to-speech component that takes the finding text and puts out a call right to the mobile device, the smartphone, for that doctor. But that doctor, after another 5 minutes, still hasn't interacted with the message. We're able to escalate to another individual entirely. We can reference an on-call schedule, a staff assignment system, and escalate to another individual that there is a critical finding on whatever device they have. That device could be a pager. So we know somewhere down the line of whether we're trying to escalate to we're trying to reach Dr. Page, and we try Dr. Page on her smartphone, and we don't get Dr. Page on her smartphone. Dr. Page might also be carrying a pager, because we often see both devices or multiple devices being carried by one individual. We can prioritize so that certain messages go to Dr. Page's smartphone, while certain messages go to Dr. Pager's pager. Dr. Page's pager. Easy for me to say. So with that, Tom, I will hand it back to you to talk us through some of paging's future.
Thank you, Gerard. Very good information. And circling back to the paging environment specifically, that goes hand in hand with all the capabilities of our software products that Gerard talked about. Paging is an older technology, but it's not a dead technology. It's a technology that we continue to invest in and invest significantly in to make sure it remains a valid technology in today's day and age. As we've already mentioned, we have over 1 million subscribers in the United States. I know we are the largest U.S.-based company, and based on my unstructured analysis of the world paging market, we believe we're the largest paging market customer in the world environment. We own and operate our own nationwide networks, both one-way and two-way. We also own and operate in-house paging networks for customers that need them. One of the ways that we've been able to modernize the technology that underlies the paging environment is, years and years ago, the primary infrastructure manufacturer for the paging environment was a company called Glenair. Glenair exited the business in year 2000. We invested in owning that. We bought the company from them basically, and helped a subset of the old management company continue to run it until 2007, when we actually took over complete control of that environment. Because we did that, we actually have all the intellectual property right and source code for the paging infrastructure that has been in service for decades. And to this date, the vast majority of the paging infrastructure in the U.S., in the worldwide market for paging, is actually stopped development and manufacturing in 2000. So if you have a paging switch or a terminal out there, the newest it can be is 17 years old. Reality is probably 20 to 30 years old. But we as a company as Spok wanted to make sure that we had a reliable infrastructure, not dependent on architecture that was 30 years old, to be frank, and no availability to buy parts. So because we own the IP and the source code, we were able to basically port all that software over to where now our paging infrastructure, from a switching and batching methodology, runs on the same computer systems in your data center in your hospital. It runs on HP or Dell servers, runs Linux operating system, SQL databases. It's no different than any other IT system in your environment. By doing that, it enabled us to have an infrastructure that we can be confident we can maintain and support and have at a high availability for you, not only now, but for many, many more years to come in that environment. And we continue to invest in that environment. But we didn't forsake any of the strengths of paging, the core paging functionalities of overlapping RF coverage. In any given time in our paging network, your pager is going to see energy from somewhere between 3 and 5 transmitters. What that means is, if there's a single transmitter failure, you don't have a degradation of services, because your pager is still getting energy from the remaining transmitters that are on the network. We also communicate with all of our transmitters that are geographically spread around the country. There's a bit more than 4,000 of them, through satellite communications versus counting on the wireline phone companies, the AT&Ts, Verizons of the world, which is becoming more and more important because they've all announced they're getting out of the wireline business. So connecting your control point to a transmitter over a phone circuit that AT&T is controlling that they really don't want. It's not their business. Their business is wireless like us. They're moving everybody to the broadband. They're not investing in the wireline infrastructure. We do it through a satellite communications network using what's called a VSAT technology. But we don't just do it with one satellite network. We have two separate satellites, two separate geographically separated uplinks, and it's like a checkerboard. Every other transmitter is controlled by the other satellite. So even if there was a satellite failure or an uplink failure, half of our network would still be running. And because you're seeing energy from 3 to 5 transmitters, you'd still have reliable street-level paging coverages in that environment. We operate a carrier-grade operations center. We're not a traditional IT shop that most of the help desk goes home at 5 o'clock in the afternoon. We are operated 24 hours a day, 7 days a week, 365 days a year. We have never shut down our Plano operations center, and I've been with the company off and on for 30 years. So we take it seriously. It's staffed 24 hours a day with qualified engineers that not only monitor the health and welfare of the network, but are empowered to take corrective measures. 68% of every anomaly within the technology environment of Spok is rectified by the operations center directly. They don't have to engage anybody outside themselves. What does that mean? That means our mean time to repair goes way, way down. If you use an on-call methodology, you find an alarm, you call someone, they get out of bed, they get their laptop powered up, they VPN into your network, then they start troubleshooting. Best case, that's a 20-minute outage before they even start working on it. Whereas we have a staff that are already up there, already on the system, their action from an identified anomaly to take an action on it is measured in seconds, not minutes or hours. So that really goes to the survivability of our network. Also, because such a vast majority of our pagers, 78% of all the pagers in our network are in healthcare. We have some government and other business, but it's healthcare. So we design our processes and procedures around healthcare primarily. A lot of IT departments do maintenance, backups, fixes Friday night, Saturday night, right? Well, we all know Friday night and Saturday nights are very, very active environments for EDs, right? Because people do things they probably shouldn't do, and they're very active. So we're not going to take your communication system down at midnight on a Friday night when you've got a very active ED. We're going to do maintenance at 2 o'clock in the morning on Sunday morning when we have done analysis that strictly says that is one of the least occupied times for ED. So it's not just the technology, it's the whole mindset of running operations that are designed for 24/7, 365-day-a-year operations. So the next slide, again, some of the strengths. I touched on this earlier, so I won't go into depth. But again, our RF network, multiple satellites, overlapping coverage, very high-power transmitters, about 3,500 watts effective radiated power, and is very survivable compared to the broadband technology, not only because broadband gets oversubscribed during disasters, but because of the underlying technology of mobile communications, it is a one-to-one relationship between your phone and a transmitter that's on the broadband network. If the transmitter goes down, you have no coverage in that area. Or if it gets oversubscribed, you have no coverage in that area. They physically cannot overlap their coverage because that defeats the purpose of cell coverage and micro coverage and picocell coverage, et cetera. So there's very strong advantages to paging over broadband in that regard. Again, we take our systems very seriously. We report our overall network availability. We publish a rolling 12-month availability report every month. Any one of our customers can have it. We're proud of it. And we have an average of 99.92% availability month over month over month. It's very static. It gets like a boring chart because it doesn't change. But that's a good thing, right? Again, we run carrier-grade operations. I already talked about that. And our methodology for our paging environment, our primary central point of operations is in Plano, Texas. So most of the systems down there that are integrated to the page environment are designed in a redundant fashion. So if there's a server failure or a disk drive failure, it automatically switches to the backup system. But we don't stop there. We actually keep a disaster recovery facility in Stockton, California that is a hot DR site. It's no uptime. Those systems are always running. We can move to them in seconds and keep the networks running if there was a disaster in Plano that precluded us from using the Plano facility. So we take redundancy, disaster recovery, all those things going in to make sure we're designing and building and providing a fully carrier-grade 24/7 critical communications environment for our customers. with that, I think Paige has got some questions, or we're going to open to questions, but we might have talked a little long, so we have about 15 minutes or so for questions, right?
We do. Thank you so much, Tom and Gerard, for that insightful presentation. We will take some time now to answer your questions, and it looks like we've had a few that were submitted already. If you have a question, just a reminder to please submit it in the questions box in your GoToWebinar toolbar, and then we'll answer as many as time allows. So our first question is, with Spok encrypted paging, how is the message transmitted between the Spok system and the pager transmission system?
So for end-to-end encryption, again, this is one of the differentiators that we've done compared to some of the other implementations of encrypted paging. Is there has been for many years the ability to get an encrypted message from the customer's data center, the customer's location, to our uplink, our control center environment. You can do secure HTTP, you can do WCTP over a VPN link, many protocols and many methods of secured communication. So we didn't reinvent the wheel. That's been there for years. So in most of our healthcare organizations, we actually do a site-to-site VPN. So all communications between your operating console systems or your message generation systems to the paging central point of operations, it has been encrypted for years, already is encrypted. We didn't reinvent that. So then from the data processing center, we then re-encrypt that message using the AES 128-bit encryption method algorithms from the central point to the pager, and then the pager the software is capable of decrypting the message.
Thank you so much. Another question, Gerard, I'll pitch this one to you if you want to start. Can alerts, alarms, and test results be sent to both my secure messaging app and an encrypted pager?
Yeah, we can allow for that. So we can allow for kind of two methods of that. So we can deliver to multiple devices being carried by one person, either as a tiered structure. So perhaps you want to receive a critical test result first on your smartphone through the encrypted application, and then if we don't get you on your smartphone after a set threshold, we can then escalate to another device such as your pager, or we can deliver at the same time. It's really up to the individual recipient's preferences.
Thank you. Another question here: how can PHI be obtained from pagers that are not encrypted?
Very good question. Because for the input of the message from the healthcare organization to the input of the paging network, that's encrypted, and you really can't breach that environment. And even if it's unencrypted, the likelihood of a breach, you would have to hack into a network, and we have the same security protocols as most people do with firewalls, et cetera, that would antivirus software, et cetera, that would include that. The weakness in an unencrypted one-way or two-way paging network is someone with a paging receiver can actually go and listen, if they're in the same geographic area as the pager, just listen to the over-the-air broadcast of the message and decode it. The decoding software is readily available on the internet. I will point out it is illegal to do that. It's a violation of federal law to do that. There was a case last year where some college student actually did that and was republishing pages on a website, and we cooperated with the FCC and the FBI, and that person is actually being prosecuted. So it is illegal to do that, but it's technically capable that since it's unencrypted message over the air, if you have a computer and a receiver and some decoding software that's readily available, you can decode the paging messages and see them. But it is illegal to do so.
Thank you. Another question, is this paging network applicable in Canada?
The Spok does not run a paging network in Canada. There are paging companies in Canada. The three prominent ones are PageNet Canada, Bell Mobility, and Rogers Communications. They all three run paging companies up in Canada. We do have roaming agreements with PageNet Canada. So there are, if you procure the coverage, that a Canadian customer can roam to the United States and a U.S. customer can roam to Canada. We used to have a much more robust, you used to be able to go to the Caribbean and all that kind of stuff, but as paging got a little smaller over the years, it's really relegated to just us in Canada now.
Excellent, thank you. Another question here, can the paging connection between the customer and Spok be non-internet based, for example, a private circuit?
Yes. We're not seeing a lot of people do it anymore. It used to be the prevalent way of doing business, but we're seeing where customers are not doing that. Again, it's a fixed cost, and the average cost of a long haul circuit from like AT&T to provide connectivity from a healthcare organization to our center in Plano is at least $600 a month. So that's a fixed recurring operating cost to do that. But then again, with the dominant interconnection carriers putting less and less focus on the wireline business, we're finding those are becoming less and less reliable. The number of tickets we have to open with the wireline phone companies goes up constantly, and the time to repair goes up as well. So the quality of that interconnect is becoming less robust as a properly designed internet connection. We have full diverse routing of internet connections into our Plano facility, and we find that most of our healthcare organizations have the same thing. So you can have a diversity routing through two different ISPs, and then you could put up an encrypted environment through a VPN environment to pass traffic, so that way. So, but you can technically do it. It's just we're not seeing a lot of customers asking for it because it's got a higher fixed operating cost, and its quality is going down every year because of the wireline nature of the wireline business.
Oh, thank you. Another question, can a local transmitter support encryption?
It's not really a transmitter. Well, I guess I'm reading into this as an on-site network. We can build you an on-site network as long as it's controlled over our satellite network. We have two flavors of on-site networking, our networks, on-site networks. We have an old school one where the entire paging network is built in your environment, where you have to have a paging terminal, an encoder, a transmitter, and then pagers that broadcast out. But we also have the ability where we can put you on what we call a private medical messaging network, where it's the same transfer we use for our wide area network, same architecture, same satellite control, but it's a dedicated frequency. So it's not a shared channel. It's a dedicated channel to that healthcare organization, but all the same architecture for the environment. Helps us with repair times and cost because our technicians, we know they have because it's the same as our wide area network, we know they have the spare parts and everything already in their trucks, so we can recover fast from that perspective. So if it's controlled through our satellite network, what we call a PMMN, a private medical messaging network, it can be encrypted. If it's 100% on-site, we do not support encrypted pagers on a total 100% on-site private network.
Excellent, thank you. It looks like we have time for probably one more question. This one, maybe Gerard, I'll put your way. Can I reap the benefits of connecting paging on pagers that aren't encrypted? So, for example, like a building alert to an unencrypted pager since that doesn't have any PHI.
Yeah, we can absolutely do that. So these non-clinical alarm systems, door access control, fire alarms, and any of those types, as you mentioned, because they don't have any sort of patient data at all and don't require an encrypted path, we can absolutely put those out to non-encrypted pagers or any device.
Excellent, thank you. It looks like that is the end of our time today, so we'll go ahead and conclude there. If we were unable to get to your question, we will be sure to follow up with you. And if you'd like to chat with a Spok representative on the topics we discussed today, you can do so using the link in the chat box. You can also continue the conversation with fellow attendees by using the hashtag #SpokWebinar on Twitter. And follow us on Twitter, LinkedIn, and Facebook to get all of the latest news from Spok, as well as industry news and trends. Thank you all again for joining us. We hope that you found this webinar informative and that you have a great day.